Hello, everyone. And today it's my great pleasure and privilege to introduce Dr. Bill Westra. He's currently a professor and the vice chair of pathology at the Icahn School of Medicine at Mount Sinai Hospital. He received his undergraduate degrees from University of South Florida and then his MD in University of Florida. He pursued his AP resident training in Johns Hopkins and followed by a surgical oncology pathology fellowship in Memorial Sloan Kettering Cancer Center, and then was recruited back to Johns Hopkins University and rose to the rank of full professor. Last year he moved to the Mount Sinai. And Dr. Westra is a very productive and researchers and also excellent educators. He organized an excellent research team in Hopkins to study head and neck cancer. I think their research really revolutionized the treatment of head and neck cancer, and especially HPV-related oropharyngeal squamous cell carcinoma. And he published more than 400 papers, and most papers is clinical related and really change how we manage the patient. And he's been serving in nationally and also within the schools, and to be in editorial board members in many journals. And today he's going to tell us how they discovered HPV as a causative agent of head and neck squamous and how they changed the management of the head and neck cancer patient. Let's welcome Dr. Westra.
Thank you. I need a bit of a cold here, but we're going to struggle through. So, if you've been paying close attention, you may have noticed that some changes have recently been written into some of our most authoritative textbooks on tumor staging, tumor classification, really to reflect some findings over the last decade or two that have absolutely shaken the oncology world. So if you were to flip through, for example, the most recent now 2017 classification of head and neck tumors, you may notice that unlike in the past, where all prior editions really have addressed the oral vault as a single chapter, with the 2017 edition, that oral vault has now been divided into two separate chapters, the oral cavity proper and now the oral pharynx. HACC has pretty much followed suit here, really all in an effort to compartmentalize a very specific region of the anatomy of the head and neck that is very predisposed to HPV infection and HPV-related tumorigenesis. To the point where if you go back and actually look at all of these prior editions, you see no mention of an HPV-related form of head and neck cancer, where in the 2017 edition, it's recognized as really now dominating the head and neck cancer landscape. So, again, thanks for having me come to talk about HPV-related cancer today. What wasn't mentioned is I was actually born in Wisconsin, so it kind of feels like a homecoming to be here back in the Midwest, but you've been great hosts, so thank you very much. And what I'd like to do in our time together is, I guess for me to kind of step away from my role as a pathologist and a scientist, and really more revert to the role of a storyteller and take you through the story of HPV from around 2000 to 2018 and how it's been identified as being a major player in a subset of head and neck cancers. I have to acknowledge from the beginning that this storyline here has been absolutely driven by the development, by the refinement of various HPV detection strategies. And it really shouldn't surprise us so much that we've seen such an evolution in these strategies when one begins to consider the biology of these HPV-related cancers, right? So from the time the virus actually infects the host and elicits this immunologic reaction to where the virus actually enters the cell and then integrates its DNA into the host genome, to the transcription of these viral mRNA transcripts, to the translation of these transcripts into these viral oncoproteins, and then to the disruption by these viral oncoproteins of the cellular machinery, giving rise to, among other things, just high levels of expression of the cellular protein P16. Well, each one of these biologic steps really represents a potential target for HPV detection. And I think what's really cool about where we are now, where these assays have taken us to, is that we as diagnostic pathologists can now actually, look through the microscope and actually visualize each one of these biologic steps. And that's really what I meant to show here. So in this lower panel is kind of a more traditional DNA in situ hybridization assay where these brown signals indicates the presence of viral DNA. To the right here is kind of the next generation RNA in situ hybridization, where here these signals tell us not only that virus is present here in the tissue, but it's transcriptionally active. As these transcripts are again translated into viral oncoproteins, we see disruption of the cellular machinery with high levels of expression of P16 very conveniently to these levels that can be easily detected immunohistochemically. And then all of these steps culminate in a very characteristic microscopic phenotype for these HPV-related cancers, and we'll spend some time looking at that. When it comes to this story of HPV and cancer, this was a story that in the past was told almost exclusively in the context of GYN oncology, right? When it came to head and neck cancer, really the only recognized antagonist in that story was smoking. I remember this time early on in my career where there was just a great reluctance to even consider an alternative cause of head and neck cancer, particularly by the NIH and other funding agencies. But the plot of this story took a major twist in 2000, and this was the year that a collaborative team at Hopkins first reported a study which I think provides very compelling evidence that at least a subset of head and neck cancers is caused not by smoking, but rather by a viral etiology. So since 2000 then, what we've seen is the oncology community really transitioned from a very initial reluctant acceptance of an HPV-related form of head and neck cancer to now in 2018 just fully embracing this concept in the clinical arena. Now, some may not like this too much, and you might be quick to point out that HPV was detected in head and neck cancers long before that 2000 publication. This was the earliest study I could find where these investigators actually were able to detect HPV in an oral squamous cell carcinoma. But I would just point out that the mere detection of a virus in a cancer doesn't necessarily establish it as being a causative agent. And I think these investigators very honestly acknowledge that, and even almost prophetically look to the future, saying that further confirmatory evidence with other techniques, such as in situ hybridization, is still really needed to establish this causation. Well, what evidence do we now have then that HPV is actually a causative agent in the development of these head and neck cancers? Well, we certainly have a large experience with the cervix to establish the biologic plausibility of HPV as being a very powerful carcinogen of the human epithelium. We now have growing epidemiology studies that have shown a strong correlation between exposure to HPV, primarily through high-risk sexual activities, with then the subsequent development of these HPV-related cancers really in a dose-response relationship. And then there is just mounting biologic evidence to indicate that the virus here is not just along for the ride as some passenger virus. We know that it's clonally present in these tumors, is transcriptionally active, and again, these viral oncoproteins are known to have very powerful carcinogenic activity. And then finally, the other thing that these detection assays have really allowed us to do is to now stratify head and neck cancers on the basis of HPV status. So we can now use HPV detection to separate HPV positive from HPV negative tumors. And this has allowed us then to discern that these HPV positive cancers are very distinct from their HPV negative counterparts. They're genetically distinct. They are clinically very distinct, and really the focus of our discussion today is how they're pathologically quite distinct as well. This graph shows some of the epidemiologic differences between these tumors. So the curve on the yellow, highlighted with yellow, are these HPV unrelated or smoking-related oral cancers, again showing this declining incidence, really reflecting diminished smoking activity in the U.S. population. But highlighted here in the blue are these the rising incidence of these HPV-related cancers. And as you can see, 2004 was a landmark year, in that this was the year these two curves met and then began to deviate to the point where now, 2018, if you were to go through our clinics, our operating rooms of patients with these oral cancers, more likely than not, those would be HPV-related cancers. And the patients we're seeing in our clinics with these HPV-related cancers look very different from the prototypic patient who used to come to mind, right, when we used to think of oral head and neck squamous cell cancer, kind of that old man, usually well into his 60s, 70s, usually a long history of cigarette smoking, often associated with alcohol consumption, usually of lower socioeconomic status. But again, this prototypic patient looks very different from the patients we're now seeing with these HPV-related cancers. These patients tend to be young, white men, usually in their 40s, 50s, 60s, usually of upper socioeconomic status, often very highly educated. And very importantly, these patients often do not report any significant history of cigarette smoking or alcohol consumption. So I was in my 40s with a young son, and my wife and I were building a life around him. And that's when something from my past threatened to take it all away. What Mr. Reynolds, this long-term HPV cancer survivor, is referring to in this Reader's Digest article is that, again, these more traditional risk factors, smoking, drinking, have now been replaced by some very non-traditional risk factors, namely those related to high-risk sexual activity. Anybody know who this is?
The guy in the TV show.
That's right. So this is, I had to look at some Dr. Max Goodwill on the new Amsterdam medical television series. I saw part of the first episode where he was diagnosed with throat cancer. And so I'm assuming that he has an HPV-related cancer. I only bring this to your attention for the way that even now Hollywood seems to want to kind of cement into our imaginations now the typical demographic of patients with these HPV-related cancers. And I would just say be a little careful. So in this graph on the left reflects some of the data that we've recently published from two very different patient populations. But what it shows is the rising median age of patients with these HPV-related cancers over the last 10 years in particular. So when we first started tracking these patients back in 2000, I would never see a diagnosis of HPV-related cancer in anybody over 70, where now it's very commonplace to diagnose these patients in their 70s and even 80s. So even that demographic we're seeing shifting. Again, just to emphasize one more time that these HPV-related cancers very distinct from their HPV-negative counterparts with a distinct demographic profile, risk factor profile, genetic profile, clinical profile. But again, for our purposes today, we really want to reflect on their distinctiveness in terms of their pathologic features. So really 4 main objectives for our time together. One is just to go over those characteristic morphologic features that help us to identify these HPV-related cancers. And along the way, we're going to point out how some of these same morphologic features can actually really challenge long-standing traditional paradigms about how we perform very fundamental activities as pathologists, how they can confound things like tumor staging, tumor grading, tumor classification. We're going to spend a little bit of time talking about methods of HPV detection, and then we're also going to point out some very specific diagnostic scenarios where knowing HPV status can actually directly inform the diagnostic process. So in terms of morphology, just by way of contrast, this would be our typical smoking-related oral cancer. So these tumors really invariably arise from dysplasia and carcinoma in situ of the overlying surface epithelium. As these tumors infiltrate, they tend to elicit, a very prominent desmoplastic stromal reaction. And the prototypic tumor is moderately differentiated, showing these zones of overt cytoplasmic keratinization. As it turns out with our HPV-related cancers, not only are these features not well developed, but they're typically entirely absent. So this would be a typical HPV-positive cancer. So not only do these tumors target the tonsils, but they specifically seem to target the tonsillar crypts, where the surface epithelium is generally intact, really lacking any dysplastic alterations. As these tumors infiltrate, they tend to elicit oftentimes very little in the way of a fibrosing desmoplastic stromal reaction. As they infiltrate, they tend to do so as these expanding lobules, often with the central cellular necrosis. This is a P16 immunohistochemical stain, again allowing us just to kind of track the distribution of this cancer in the tonsils, really highlighting again how these tumors really seem to take origin from the deep tonsillar crypts. And when they do involve the surface, it's usually as they spill out of the crypts onto the overlying surface with very sharp transitional zones. So one, again, does not see those broad areas of dysplastic alterations. Again, as these lobules infiltrate, they're often heavily permeated by these tumor-infiltrating lymphocytes. The tumor cells themselves tend to have very enlarged hyperchromatic nuclei, very indistinct cell borders. The presence of keratinization is usually either focal or entirely absent, and together then that imparts a very basaloid appearance to these tumor cells. When these tumors metastasize to regional nodes, they're often associated with cystic central degeneration, where the lining of these cysts, again, are lined by this basaloid epithelium thrown into these folds, very much resembling almost, again, those tonsillar crypts. Occasionally, you'll have these HPV-related cancers which can deviate from that characteristic morphologic appearance, and when it does so in reproducible, consistent ways, these are sometimes set apart as variant forms of HPV-related head and neck cancer. Here's a fairly comprehensive list of now the variants that have been reported in the literature for these HPV-related cancers. And we're just going to touch briefly on a few of these. So the first one we reported was a lymphoepithelial variant. So when I say lymphoepithelial, I'm referring to these tumors that have a very syncytial, molded cytoplasm, conspicuous central nucleoli, vesicular nuclei, and then a very brisk plasmacytic lymphoid background. Now in this variant, not only are these lymphoepithelial features present, but they're so highly developed that these tumors morphologically really become indistinguishable from EBV-driven nasopharyngeal cancer. So now where this becomes an issue, and it's actually helped shape diagnostic practices, are in scenarios like this, where you have a lymph node metastasis, patient with an unknown primary tumor, demonstrates very well-developed lymphoepithelial features. One can no longer assume that this is an EBV-driven cancer from the nasopharynx. Statistically, we know it's probably much more likely in the U.S. population that this is actually an HPV-driven process from the oropharynx. So when you encounter this scenario, the pathologist is really now compelled to do a more extensive oncovirus analysis. So an analysis that includes not just an EBR, but markers for the presence of HPV as well. This is a very important HPV head and neck cancer variant, the small cell variant. So when we initially reported our series, again, almost all of these arose in the oropharynx. A few cases you'll sometimes encounter in the sinonasal tract. And this is pretty characteristic. So most of these small cell carcinomas actually arise in association with a non-small cell component. So if you look here, kind of lower left is our small cell component. And you can see it kind of merging with these cords of non-keratinizing squamous cell cancer here in the upper right. So morphologically, under the microscope, these HPV-related oropharyngeal cancers look just like small cell carcinomas in the lung. So comprised of these sheets of small anaplastic cells, high NC ratio, scant cytoplasm, molded nuclei, very high-grade cellular features, necrosis, apoptosis, mitotic figure, so morphologically identical. Now, if one were to do immunohistochemistry, what you would see is as these tumors undergoes this small cell transformation, one tends to see loss of markers of squamous differentiation. So one sees loss of cytokeratin 5-6, P40, P63, with the acquisition of neuroendocrine markers such as synaptophysin and chromogranin. But as these tumors undergo this small cell transformation, they consistently retain the presence of HPV. Just some observations from that initial series. Really highlighting how aggressive these tumors are. So most of these patients present with advanced stage disease, so not just with nodal metastasis, but with distal metastasis, and these patients typically experience these rapidly fatal outcomes. So since that series, this is a fairly comprehensive look at what's currently been reported in the literature. So rare tumors, only 19 cases reported so far. But if you look at the follow-up on these patients, of these 19 patients, 15 are either dead of disease or alive with widespread distant metastasis. So here's the point I want to make. With these variant forms of HPV-related oropharyngeal cancers, the presence of HPV really trumps any morphologic features, with the one exception being the small cell variant. So here the phenotype really trumps the presence of HPV in terms of what to expect regarding clinical outcomes.
Can I ask a question on that point real quick?
Of course.
NCCN guidelines for 2018 obviously have made a big change about utilization of both P16 immunostains as well as detection of HPV and squamous cell carcinoma as far as clinical management, where our colleagues are implementing it. Is that taken into account? I don't recall seeing that component of the small cell variant in the NCCN guidelines. I don't know if you happen to know.
So we like if you read the current CAP guidelines for like HPV testing, it specifically says don't even bother to test
In the
these.
small cell.
Don't even bother to, because it doesn't
Because you
matter.
don't want to go
Right,
there.
right,
So
right.
it's kind of the whole on us to
Right.
prevent it. 'Cause
And ju-
a lot- we, in the molecular lab, we
Mhm.
get a decent amount of HPV testing across
Mhm.
on head and neck cancers.
Right.
And, we obviously sometimes have to kind of correlate both the morphology
Right.
and the HPV
Right.
results into those NCCN guidelines beyond what the CAP is.
Yeah. And just to jump on with just one other comment. So small cell carcinomas are often P16 positive, whether it's HPV related or not. And so, yeah, so if you want to really determine HPV status, P16 alone really isn't, really has no role. You would want to do PCR in situ or something like that. So earlier I mentioned that these same morphologic features which typify the microscopic appearance of these HPV-related cancers can also be a source of significant confusion. They can confound sometimes very fundamental activities that we perform as diagnostic pathologists, things like diagnostic terminology, histologic grading, and even this very fundamental distinction between non-invasive and invasive disease. So I'd like to begin by discussing this point. And as we do this, I'm going to ask you to do something for me. I'm going to ask you to, just for the moment, just kind of letting go of some long-held traditional paradigms for the way we think about this transition. And for the moment, just be open just to a new way of thinking about this. Now, in order to have this discussion, we're going to all need to share some fundamental knowledge about the human tonsil. So the human tonsil, as you know, represents an immunomodulatory structure, right? So it forms part of Waldeyer's ring, or this sheath of lymphoepithelial tissues, which is uniquely designed for antigen transport. Now, what's so nicely shown here in this original drawing by Max Brodel is that the surface area for antigen processing is greatly expanded here by the formation of these tonsillar crypts, or these deep complex infoldings, which expand that surface area by over 700-fold. But it's not just that, but these tonsillar crypts are lined by a highly specialized type of lymphoepithelium known as the reticulated epithelium. Again, very uniquely designed for the transport of external antigens to the internal lymphoid stroma. Now, if we had an electron microscope and could point it right into the heart of one of these crypts, we would find that it actually has some very unique ultrastructural features as well. And for our purposes, we're going to just focus on this interface between the epithelium and the underlying lymphoid stroma. And what we would see is that this basement membrane here is very fragmented. It's very disruptive, disrupted with these large holes in it. And then residing on top of this fragmented basement membrane is a basal cell layer, which itself is very non-contiguous with these large gaps. And together then, this allows for the free migration of antigen-presenting cells, lymphoid cells, back and forth between the lymphoid stroma and the reticulated epithelium. So it's a very busy lymphoid trafficking area. So if we begin then to consider the anatomic, the microscopic, the ultrastructural makeup of the human tonsil, we begin to appreciate why we can't apply traditional paradigms, criteria that allow us to assess for invasive tumor growth. So, for example, probably the most important histologic feature would be downward extension of the tumor into the underlying subepithelial tissues. But really not a relevant feature here for these HPV-related cancers, which take origin beneath the surface in those tonsillar crypts. Stromal desmoplasia, really a telltale sign of invasive tumor growth, just not well developed in these HPV-related cancers. I spend a lot of time as a head and neck pathologist kind of just scrutinizing that epithelial, subepithelial interface, looking for microinvasive growth. Here that interface is entirely obscured, again, by this busy lymphoid trafficking. And then, if you think about it, if you go way back to your earliest training in pathology, right? So think back, medical school, sitting in those pathology labs. What's the first thing they taught you when they taught you about cancer? So they taught you that invasive growth is really defined as being disruption of the basement membrane. Where here, in this reticulated epithelium, even that basic biologic principle doesn't even really apply where the basement membrane is innately disrupted. So I think for all these reasons, it helps explain why it's so common to encounter these patients with HPV-related cancers who present with these lymph node metastases, who have such tiny and even occult primary tumors. This is just a case in point. Again, patient presented with lymph node metastasis. They couldn't find the primary tumor. Bilateral tonsillectomies, removed a portion of the base of the tongue. Very thorough microscopic evaluation showed this single 1 millimeter focus of HPV-related disease, which still seemed to be confined to the tonsillar crypts without meeting any of those traditional histologic features for invasive tumor growth. So I would argue, and it's been my stance, that until we can better appreciate just what this transition from non-invasive to invasive tumor growth actually looks like with these tumors, that we should regard all forms of HPV-related disease in the tonsils as being potentially malignant, even in the absence of those more traditional histopathologic criteria. So in my practice, I don't even recognize an in situ or dysplastic form of HPV-related disease in the tonsil. And this now has been an approach, a concept taken on by the newest AJCC staging. So unlike non-HPV-related cancers of the oropharynx, where they still retain this designation of carcinoma in situ, this staging category has been completely dropped from our HPV-related cancers. Well, how about histologic grading? So histologic grading, of course, is a semi-quantitative measurement of tumor differentiation. How does a tumor resemble a normal epithelium from which it is derived? So well-differentiated tumors are those tumors which closely resemble normal epithelium of similar type, right? And then poorly differentiated tumors barely resemble normal epithelium of similar type. So I think the question we need to ask ourselves when dealing with these HPV-related cancers is, what are we using as a reference point to determine tumor differentiation? Now, there is a long-standing, entrenched notion that these HPV-related tumors are poorly or undifferentiated cancers. Really a notion based on the very immature, very basaloid appearance of these tumor cells, which admittedly do significantly depart from that stratified squamous epithelium lining the surface of the tonsils. They do, however, maintain a very close morphologic resemblance, I think, to the reticulated epithelium. So in this photomicrograph on the left with the black asterisk is our normal non-neoplastic reticulated epithelium, and then on the right, designated with the red asterisk, is our HPV-related oropharyngeal cancer. Here is a view of a deep tonsillar crypt lined on one half by entirely normal non-neoplastic reticulated epithelium, and then colonized on the other hand, on the other half by fully malignant HPV-related cancer. And sometimes I'll show this to my colleagues and really defy them to tell me which is which. And sometimes you really need to come in with a detection assay like a P16 to really help make this distinction. So I would argue then these are not poorly or undifferentiated carcinomas, but rather highly differentiated tumors for the way they maintain this resemblance to the reticulated epithelium. And then finally, you know, the common use of the term basaloid as a diagnostic descriptor of these tumors runs a very real risk of drawing an erroneous connection between these HPV-related cancers with the basaloid variant of squamous cell carcinoma, which is shown here. So the basaloid variant of squamous cell carcinoma of the head and neck is really set apart by two hallmark features. One of those being a very aggressive clinical behavior. So most head and neck pathologists believe that stage for stage, this basaloid variant behaves even more aggressive than conventional squamous cell cancer. The other hallmark feature which sets these tumors apart is their very basaloid morphology. So just like HPV-related cancers, keratinization, when it's present, tends to be a very minimal component, but most of the tumor grows as these expanding lobules, central cellular necrosis, again, very basaloid appearance of these tumor cells. So significant morphologic overlap with our HPV-related cancers. So we did a study where we looked at like over 40 basaloid variants of squamous cell carcinomas from all anatomic subsites of the head and neck. And then we performed HPV analysis here with an in situ hybridization technique. What we found is that a subset of these tumors, particularly those arising in the oropharynx, were in fact HPV positive. Now this turned out to be clinically very relevant. Keeping in mind what I had just said, HPV as a prognostic indicator really trumps morphology with the exception of small cell cancer. So if you look at these basaloid tumors, the finding of HPV really seems to draw out from this very aggressive tumor type associated with very poor outcomes, this subgroup of tumors associated with very favorable outcomes. This then kind of presents a dilemma then for us as diagnostic pathologists. I mean, how do we effectively use terminology now when dealing with basaloid carcinomas, particularly from the oropharynx, in a way that doesn't confuse or confound our treating clinicians? You know, through our consultation practice service, I've had the opportunity to see how pathologists from around the country really deal with this issue. And what I found is that most pathologists put these tumors, these HPV-related basaloid carcinomas, into one of four categories. So some will just leave them in this variant group. Problem, again, of doing that is you're mixing tumor types with very different clinical outcomes. So some will appropriately take these tumors out of this variant group and sign them out more descriptively as squamous cell carcinomas with basaloid features. The problem I have with this diagnosis is sometimes I think this distinction is too subtle for many of our treating clinicians who, when they see that term basaloid, at least in the past, really would respond to that as though they were dealing with a very aggressive tumor type. Others appropriately will drop the designation of basaloid and just sign these out as poorly or undifferentiated carcinomas. Again, I would argue that these are not poorly differentiated, but rather well-differentiated tumors. And the use of advanced histologic grade at least implies a more aggressive behavior. And then what's become recently much more popular is just to diagnose these tumors as non-keratinizing squamous cell cancers. The only problem I have here is it's a little too vague, I think, and it isn't really helpful in drawing that connection between the morphology with the presence of HPV. So how have I dealt with this over the years in my diagnostic practice? Well, for a number of years, it's been our routine practice to reflexively perform HPV analysis of all of our oropharyngeal cancers and those that are positive. Now we simply diagnose as HPV-related squamous cell cancers without diagnostic descriptors, without even a histologic grade. And again, going back to the College of American Pathologists' recently published guidelines for kind of the how, what, and when of HPV testing. This shows the algorithm from that paper. I know it's very convoluted, very complex. I'll just have you focus on this portion of the algorithm. So again, for any primary oropharyngeal cancer, routine reflexive HPV testing is advocated here using P16 immunohistochemistry. And those that are positive now whether it's the CAP guidelines, AJCC, or the WHO, we're all now recommending the terminology HPV positive squamous cell cancers without any further histologic grading. This chart summarizes some data we published a number of years ago now, looking at both clinical and pathologic motivations really driving requests for HPV analysis of head and neck cancer. So this was really before the time of routine HPV testing, and it really helped us to get at the why question of performing HPV analysis. And as you might expect, the majority, just over 50%, were requests really initiated by the treating clinician, who simply wanted to know HPV status to better predict clinical outcomes. Again, recognizing that HPV status is a powerful predictor of clinical outcomes. But you also might note that not all of these requests were prompted by the treating clinician. A significant subset were actually requested by the pathologist, understanding that knowing the HPV status in some instances can directly inform the diagnostic process. Probably most importantly now in helping to establish a site of tumor origin. So as you may know, this is not an uncommon presentation for patients with head and neck squamous cell cancer. So about 20% of these patients will present with a neck mass reflecting metastatic spread to a regional lymph node. Now what's always been just remarkable to me is that even though these patients clearly have biologically, clinically advanced tumors, actually finding the primary site of tumor origin isn't always that straightforward. In fact, in about 2 to 5% of these patients, they remain with occult tumors, even following an exhaustive clinical, radiographic, even a histopathologic evaluation. So these patients would routinely undergo panendoscopy, with biopsies of those anatomic subsites most likely to harbor some small hidden cancer. Well, good news, the head and neck surgeon says to this patient, exploratory surgery turned up negative. But really, the bad news for this group of patients is that exploratory surgery turned up negative. I mean, the surgeon now has no specific tumor to remove, and the radiation oncologist has no specific field to target. But we thought this group of problematic patients might benefit from a novel strategy which really takes advantage of the fact that certain oncoviruses like HPV seem to target very specific regions of the upper aerodigestive tract. So in essence then, finding the presence of virus in the metastatic implant should reliably point back to the oropharynx as the primary site of tumor origin. So we did a study where we looked at over 70 patients with metastatic squamous cell carcinoma in the cervical lymph nodes. Only these patients had very well-defined clinically identified primary tumors. We then performed HPV analysis of their lymph node metastasis and were able to detect HPV in over 70% of those patients with metastasis from the oropharynx, but in none of those metastasis arising from some non-oropharyngeal site. So what this now tells us, in this common scenario where you have a patient who actually presents with a lymph node metastasis, finding HPV in that metastasis provides very compelling evidence that this tumor actually arose from the oropharynx. Now, another very specific diagnostic scenario where knowing HPV status can inform the differential diagnosis is with these squamous line cysts of the lateral neck, where the differential diagnosis is often between a branchial cleft cyst and a cystic HPV-related metastatic squamous cell carcinoma. This table is really just meant to emphasize how this can be difficult in that because of a number of parameters. These lesions show a lot of overlapping features, including overlapping morphologic features. So, for example, these branchial cleft cysts can sometimes get infected, get inflamed, and be associated with significant squamous atypia. Where on the other hand, some of these metastatic HPV-related cystic carcinomas can look very bland. Heck, we even have described a ciliated form of HPV-related cancer with well-developed cilia. And the thing is that these ciliated carcinomas not only have these well-developed cilia at their primary site, which again, one of the things you've learned in your earliest pathology training is that cilia is kind of a sine qua non of benignancy. Here, not only is it present in the tumor, but it's retained in its metastatic site. So again, just to give you some appreciation how difficult it can be sometimes in making this very important and fundamental distinction between a branchial cleft cyst and a cystic HPV-related cancer. So here again, the finding of a virus in that epithelial lining provides very compelling evidence. For one, this is no benign developmental cyst, but rather a malignant tumor. And then secondly, this likely arose from the oral pharynx. So over the years, we have acquired extensive experience in performing HPV analysis of head and neck cancers across all anatomic subsites. And this has really allowed us to actually map out the distribution of these HPV-related cancers. And as we've made quite clear, the true hotspot is the tonsils. So over 90% of these tonsillar cancers are HPV positive, with a likelihood of finding HPV in some of these non-oropharyngeal sites, like the oral cavity proper. The larynx is exceedingly low, generally no higher than 3%. One of the exceptions is the sinonasal tract. So the first to bring this to our attention was Dr. Al-Mafti at the WashU, who found the presence of HPV in about 30% of their sinonasal cancers, usually localized to the non-characterizing subtype. We were able to reproduce that finding in our experience at Hopkins. Again, about a third of these sinonasal cancers are HPV positive. What was a little unique about our study is that we were inclusive of all primary sinonasal cancers, including those of presumed salivary gland origin. And this allowed us to detect four salivary gland cancers that were HPV positive. All actually showed a very similar morphology and had been diagnosed as a solid variant of adenoid cystic carcinomas, which we reported, and it really prompted us to go back and look at all of our head and neck adenoid cystic carcinomas. We identified 8 additional cases, all again diagnosed as a solid variant of adenoid cystic carcinoma, all localized to the sinonasal tract. And then in the next few years, through our consultation practice, we accumulated now nearly 50 of these HPV-related adenoid cystic-like carcinomas of the sinonasal tract. We now actually call them multiphenotypic carcinomas just because that salivary gland component can sometimes have more of an epithelial, myoepithelial look. Sometimes you can encounter squamous differentiation, sometimes even sarcomatoid transformation. So truly multiphenotypic. Pretty characteristic, very large, destructive local lesions. Histologically, very basaloid, so nests of these are sheets of these basaloid cells, but with zones showing more of a cribriforming architecture, closely resembling adenoid cystic carcinoma. In fact, if you were to do immunohistochemistry, what you would find is kind of a mixed component of both ductal cells as well as myoepithelial cells. Again, a cellular composition very characteristic of a salivary gland tumor. We do not, however, believe that these are truly adenoid cystic carcinomas for a number of reasons. For one, they're often associated with squamous dysplasia or squamous cell carcinoma of the surface epithelium, which many head and neck pathologists would use as exclusion criteria for a true adenoid cystic carcinoma. These tumors do not harbor the MIB-NFib gene fusion that is seen in so many true head and neck adenoid cystic carcinomas. This translocation has not yet been reported today in our multiphenotypic cancers. And again, these tumors are HPV positive, where we've now looked at adenoid cystic carcinomas and non-oropharyngeal sites and non-sinonasal sites, and you do not find any HPV positivity. Now, I have to say that when I encounter HPV outside of the oropharynx, I'm very reluctant to report that to our clinicians, just because I think there's a strong tendency for our clinicians to take our experience in the oropharynx and then generalize that to these non-oropharyngeal sites, and it's probably not a fair assumption to make. And this graph really just kind of highlights how distinctive these HPV-related cancers in the sinonasal tract are from the oropharynx. So these multiphenotypic cancers occur more frequently in women, where oropharyngeal cancer shows strong predominance in men. Again, very different morphologies. In the oropharynx, over 90% of these cases are due to HPV-16. To date, I think there's just one 16 type reported in the sinonasal tract. Most of these are HPV type 33. And then importantly, in terms of clinical behavior, to date, there has not yet been reported a regional lymph node metastasis in these multiphenotypic patients or tumor-related death. So despite the fact that they're locally aggressive, they look very high-grade histologically, rather indolent in terms of clinical behavior. So just a brief final word about HPV detection strategies. So this just shows kind of a comprehensive list of potential HPV targets, along with some of the assays used to detect these targets. Just a word of caution, whenever we think about the optimal detection platform to use in clinical samples, we really need to consider not just the strengths of that assay, but its limitations as well. So for example, RT-PCR for the presence of these viral mRNA transcripts, highly sensitive, highly specific, really the gold standard by which we kind of assess all of these other assays, but limited to fresh tissue, technically very sophisticated, just not easily transferable from the research laboratory into the diagnostic laboratory. Conversely, we have immunohistochemistry for some of these viral oncoproteins. Immunohistochemistry is simple, straightforward, easily transferable to the diagnostic laboratory, but its performance has just been too poor to use in the clinical arena. So as you know, a great deal of attention has been given recently to the use of P16 immunohistochemistry as a surrogate marker for the presence of HPV. And just like in situ hybridization, it really allows us to discern both the presence and distribution of the virus in the tissues. So this slide really dates back to when many of us were using the Ventana Inform system for HPV DNA in situ hybridization. It was really a wide spectrum HPV marker. And we were encountering about 20% of our cases that were P16 positive, but we just couldn't detect any HPV, again using the traditional DNA in situ hybridization approach with a wide spectrum probe. Sometimes when we went back into some of these tumors with type-specific probes, we could kind of detect HPV at very low viral copy numbers. But then more recently onto the market came a new assay for RNA in situ hybridization. So some of these tumors that were negative with the DNA approach showed the presence of transcriptionally active virus using the RNA approach. This prompted us to do a study where we looked at, over 40 cases of these discrepant cases. So these were tumors arising in the oropharynx, looked like they should be HPV related, strongly P16 positive, but completely negative with a traditional DNA in situ hybridization approach. 90% of these tumors showed strong expression of these viral transcripts using the RNA in situ hybridization approach. So we believe now that RNA in situ hybridization is much more sensitive and specific, very easy to interpret. With this recent automation, it's easily transferable into the diagnostic laboratory. I think Mayo is now using this, Memorial Sloan Kettering, Hopkins, many institutions around the country provides direct evidence of transcriptional activity, and many are considering using this as really a first-line platform when decisions are being made about specific individual therapies. So if you're going to triage patients to a therapeutic vaccine or de-escalate their therapy based on HPV status, you might want to perform a more rigorous analysis than P16 immunohistochemistry alone. So just to conclude then with this common question I get, well, what about P16 immunohistochemistry as a standalone marker to determine HPV status? And my answer over the years has been it's fine, provided it meets certain conditions. So for one, and the CAP has now specified this, staining needs to be rather diffuse in over 70% of the tumor cells, needs to be nuclear, cytoplasmic. These tumors need to be in the oropharynx. So as we talked about, sometimes you can have high P16 expression entirely unrelated to the presence of HPV. So once you start looking outside the oropharynx, the positive predictive value of P16 staining drops significantly. There needs to be some concordance between morphology and P16 staining. So if you have strong staining in a tumor that looks like conventional keratinizing squamous cell cancer, you might want to resort to a more rigorous analysis. And then again, so far HPV status is used predominantly as a prognostic indicator, but when we're using it actually to direct patients to specific therapies, we may want to use more rigorous analysis. So again, HPV-related head and neck cancers is clearly on the rise. Some are referring to this as a cancer epidemic. It is now just dominating the head and neck cancer landscape, which is not just affecting preventive and therapeutic practices, but what I hope to emphasize is actually shaping the way that we practice diagnostic pathology. So thank you again for your time. Thank you for having me. I know that was kind of covered a lot of stuff. If we want to get more granular, I'll be around to answer any questions.
One short one. We have a meeting at 9.
Apparently the HPV positive squamous cell carcinoma is more sensitive to cisplatin therapy compared to the non-HPV. I was wondering what contributes to that difference.
Right, so the question was, so we didn't talk a lot about its distinctiveness from its clinical behaviors, but you're absolutely right. These tumors are associated with much better outcomes. And a big question has been why. And it's not just like chemotherapy. It's whether you treat these patients with chemotherapy, radiation alone, surgery, some combination. All of those patients do much better. People think it may have to do with the immune system, recognizing some of these viral antigens and how those get turned on. Unlike smoking-related cancers that tend to arise in kind of this field effect where patients get secondary tumors, and that may play a component. But we don't understand entirely.
So if you have more questions, you can email him or call him. I think he's very accessible and it's very pleasant to talk to him. I think we consult some cases from me before.
Thank you.
Thank you.